Good morning, everyone. So today I will be covering the topic sepsis in liver failure, whether it is a disease resistance or tolerance. So we all know that sepsis is a life-threatening organ dysfunction caused by the dysregulated host response to infection. And in this, we will mainly cover the disease resistance or a tolerance in the host protection against infection. Then we will discuss our own data and what the available data from the literature that says that whether it is the resistance or the tolerance is defective in case of liver injury. So coming to the pathophysiology of infection control. So in the past few years, or if you see the many years, the major emphasis when we talk about the infection control is given to the disease resistance property. So what this disease resistance is? So it is basically the immune-mediated defense mechanism that sends the invading pathogens and that lead to the activation of the immune system.
Please use a pointer. It's a very important slide, I know.
So that lead to the sensing of the invading organ, these pathogens. They constrain it, kill or expel the pathogens. So how it does? So first you have the innate immune system that basically sense these pathogens. They get activated and they try to kill them. Simultaneously, they also present as the antigen and leading to the activation of the secondary adaptive immune system for the effective expulsion of these pathogens. And during this process, you have the two major events occurring, that is the immune activation and the cytokine storm, which is actually required for the effective clearance of the pathogens. But however, this also lead to the stress to the immune cell per se as well as the other cells in the body. And that activates the tissue damage response in the body and causes the immunopathology. And this immunopathology is basically counteracted by another type of mechanism which we will discuss later, that is called the disease tolerance. So overall, we have a lot of emphasis has been and the development has been made in this direction of infection control. We have various therapy like vaccines, antibiotics, even the plasma filtration, immune modulating drugs are coming. So what happened that during this process, so why there is a cytokine storm whenever you have an uncontrolled infection? So because of this immunopathology, there is also the damage as well as the virulence factor of the pathogens. There is a damage to the host tissue also that leads to the perpetual presence of both DAMs and PAMs. And this perpetual presence of DAMs and PAMs lead to the aggravated cytokine production by the immune cells. And this is the classical concept that says that because of this cytokine storm, there is a compensatory anti-inflammatory response also occur, and that leading to the immunosuppression, or mainly the innate immune cells, they are showing the suppressive phenotype. And during this process, if there is any secondary infection, they are failed to encounter that, and that is leading to the sepsis. So with this concept, there are various approaches has been developed and tried. However, they shows a limited success. Then what is the next? So disease tolerance. This is the host tissue damage control mechanism that prevents the deleterious effect of pathogen, and it is basically uncoupling the immune-driven resistance to the immunopathology. It acts at various levels like immunoregulation, microbial shaping, and the most important is the coupling nutritional immunity and the metabolic adaptation. So in case of this, we all know that whenever you have a aggravated immune response, so immune cells per se as well as the innate immune cells also, they try to produce the various molecules, and that lead to the immunosuppressive phenotype like T cell exhaustion or CTLA4, extra secretion of the anti-inflammatory cytokines. So this way they are trying to curtail the immunopathology. The second way is that nutrition. So it is known that the various vital nutrients are required for both immune cell activation as well as it is also required for the pathogen function. And usually these pathogens try to prevent the uptake of this molecule by the immune system. So how the immune system works, so they try to adapt into a different type of metabolic state. So in one way, they try to reduce the production of these molecules, or they adapted to the other type of molecules during this process. For example, here if I say like gut microbiota, they produce a different type of short chain fatty acids. So rather than they requiring the glucose, they are trying to adapt towards the use of these nutrients for their function. So if we see the entire course of this pathogen clearance, so you have the innate immunity activation followed by the adaptive immunity. But if you see in the background of this process, there is a process going on which is called the tissue damage control. And this tissue damage control, the central player of this is the metabolic adaptation of the immune cells as well as the other host cells. So what happened during this process, whenever you have the acute phase response, so during this process, the cells try to rely on the glycolytic process. So this basically helps them in the reducing the oxidative stress in the cells, as well as they also help in the production of different metabolite which is required for fighting the infection. However, this process also leads to the deprivation of the energy into the cells. But quickly these cells, once the infection is resolved, they have to switch towards the oxidative metabolism so that they can regain its lost energy and function. So similar to the immune cells, the host cells, like I have given example here for the renal epithelial cells, they also go towards the glycolytic process, that helping them in reducing the oxidative damage, as well as they are also helping in the working in an energy or the nutrition deprived condition. But at the same time, this will also lead to the energy deprivation in these cells. So in the recovery phase, they have to quickly switch towards the normal oxidative phosphorylation process. So what happened that during infection, how this is working and why it is needed. So if you see whenever a macrophage senses the bacteria, the first response is that in response to the LPS or binding to the bacteria to the membrane of the macrophage, it leads to the production of ROS by the activation of NOx. This NOx ROS production also lead to the change in the electron transport. So basically it suppresses the complex 1 activity and leading to the reverse electron transport that basically lead to huge amount of production of ROS. This rewiring of this electron transport or TCA cycle also lead to increased production of the metabolites like fumarate or the etocholic acid, which is required for the effective killing of the bacteria which has been engulfed by these macrophages. However, this process, if you see, there is a complete damage of the mitochondrial complex, and for recovery, the cells has to recover quickly towards or they have to restore, and that they need the mitochondrial biogenesis. And as I discussed, they like this metabolic adaptation also are the master regulator for converting them in whether they will act as a pro-inflammatory or anti-inflammatory. Like I have given example here, the succinate is required for the increased production of IL-1 beta. Similarly, the alpha ketoglutarate is required for this, the converting back towards the oxidative phosphorylation and the production of IL-10 during the resolving phase. The most important thing is that during this conversion, if the cells are still in the phase of the anabolic or the glycolytic stage, and if they have a still mitochondria damage, so these cells will not able to transform into the resolving phenotype. So the question is that why there is a poor infection control in liver disease, whether it is a systemic inflammatory response or the poor disease tolerance. To understand that, we conducted one pilot study where we have recruited the CLD, compensated cirrhosis, CLD with sepsis 12, ACLF with sepsis, and no liver disease where we have taken pancreatitis sepsis as a control. And what we interestingly observed that in all the cases, whether it is a CLD sepsis or non-CLD sepsis, if you look at the cytokine level, it is almost equal. Even it is in case of ACLF, some of them are lesser than the CLD sepsis and the pancreatitis sepsis. So it is unlikely that increased systemic inflammatory response plays any role in poor response to infection in ACLF. However, when we look the cells function, you can see here that in both CLD sepsis, it is progressively declining. When we look at the energy metabolism, they are also showing the same phenotype. So it raises the possibility that might be the disease tolerance, which can be measured by the bioenergetic state of the cells, are the major driver of the poor infection control in case of liver injury. So asking this question, we designed the study in ACLF patient where we have taken the healthy control as well as the 116 ACLF patient, including the SIRS, no SIRS, and sepsis. These are the, and here also we see that during this no SIRS to SIRS and sepsis, there is not much change in the cytokine profile. The only thing which we are observing, which was obvious also, that there is a progressive increase in the systemic endotoxemia. If you look at the number of the cells, so whether immune system is active or not, yes, the number of macrophage, the number of monocytes are high in comparison to the healthy. However, if you look at their function, they are poor. Both, whether it is a phagocytosis or oxidative burst function, which is required for the effective clearance of the pathogen. Since both these processes are an energy-driven process, so we also shows here that while the phagocytosis is mainly fueled by the oxidative phosphorylation, and the glycolysis fuels the cellular ROS production in macrophages. We further show that in ACLF, both the glycolysis as well as the oxidative phosphorylation is compromised. So OCR is an oxygen consumption rate which is directly proportional to the mitochondrial function. And ECAR is the extracellular acidification rate, which is directly functional to the, so whenever you have a glycolysis, there is a production of lactate. So in the extracellular environment, you have the more production of this acidification, and that is measured as a glycolysis process. So when we did the kinetics of these patients, we were able to perform in 8 patients, where we have taken the samples at the time of admission, 24 hours after the admission, and 72 hours after the admissions. And what we observed that the patient where you see the improvement in the energy metabolism, they are the one who are basically able to come up with the episode of disease. However, the patient who even after the intervention of the therapy are failed to improve their bioenergy, they are died. Indeed, we found that in this study that the basal respiration rate, if it is less than 25 or the ECAR less than 42.7, it is highly associated with the increased mortality of these 28 days mortality in these patient cohort. Not only predicting the mortality, but also we have found that whenever we give the plasma exchange as one of the therapeutic approach, so the patient who are able to increase their energy metabolism, they are the one who is basically responding to the treatment. So the next question comes, so what causes the bioenergy failure in liver injury? So there is one publication from Moro group where they have done in the European cohort, the metabolomics of the plasma, and they come to this conclusion that during this plasma metabolomics, that there is an increased accumulation of acetyl carnitine and defective fatty acid oxidation, which is an indication of towards the mitochondria damage. Later, another study that also confirmed that there is a mitochondrial damage and it is acting as one of the hallmark feature of the immune dysfunction in case of ACLF. Similar to this, we also observed in our study also that the monocyte of these patients having both less amount of the functional as well as the total mitochondrial biomass. So the question comes is that can we restore the mitochondrial biomass or can we rejuvenate the energy process of these cells? So here we have used, so I would like to say that like MSC, we all heard about this molecule, mesenchymal stem cells. They produces a lot of cytokine growth factors, that has been known, but there is also one very peculiar property of MSC is that it donates its mitochondria to the damaged cells and helping them to in the recovery process. So we try to exploit this mechanism, and in vitro we first checked that whether MSC can donate its mitochondria, and indeed we found that MSC donate its mitochondria to the monocyte, leading to the increase in the mitochondrial biomass as well as the potential. It increases the mitochondrial respiration as well as the phagocytosis in vitro condition. Similarly, in vivo, in animal model, also showing the similar phenotype. So with that, and there is also one paper in the case of kidney injury, there also they have shown that human mesenchymal stem cell transplant into the mice stimulate the renal tubular epithelial cells and enhance mitochondrial function. So with this understanding, we perform a pilot study in human, and there we also see that while the number of monocytes was not much changed with the mesenchymal cell therapy, there is an increase in its phagocytic activity. There is an increase in the total mitochondrial biomass as well as the mitochondrial respiration post-therapy. As per the safety of the infusion, we, in case of minor adverse event, yes, we observed the fever and shivering in most of the patients, but there was no major adverse effect. In terms of clinical changes, yes, most of the clinical improvement at 30 days, we found it is more prominent in ACLF compared to the CLD patient. So the next question is why liver injury compromise the host disease tolerance? The first thing is that liver itself is acting as a very important organ in terms of infection control. And this was in 2014 itself, it has been established that liver is acting as a vascular firewall. So what these guys has shown, two very important thing is that in this study that liver, yes, if there is a gut damage, there is an increase accumulation of the bacterial product in the circulation. If you damage the Kupffer cell itself, that can also lead to the increase of this process. And when they compare it in the human disease, what they major things is this increased gut commensal macrobiota translocation established even prior to the onset of liver inflammation and fibrosis. So though you have the macrophages, you have the monocyte there, but functionally these cells has been compromised. And recently, and there is another paper back-to-back came which clearly showed that, because this was the initial understanding that the spleen is the major organ which is playing a major role in the infection control, particularly related to the, if it is a systemic infection. And there also they have shown that more than 70% of the clearance is basically taken care by the liver, and only 30% is taken care by the spleen and the adaptive immune system. So in a way, if we say there is a defect in a liver macrophage system, will increase the systemic load of invading pathogens and systemic endotoxemia. Recently, this paper has came which suggests that during the NAS process, because this is also very triggering question that what basically lead to the transition of steatosis towards the fibrosis and inflammation. So there also they show that during this very early stage, there is a defect in the this macrophage erythrocytosis process, and that basically lead to the transition from the steatosis towards the inflammation and fibrosis. In our model of animal injury, we also found that during the course of liver injury, the liver macrophage number is inversely proportional to the systemic endotoxemia. And this loss of macrophage started even very early in this process. The kinetic proteomics of these animals, the most interesting thing we observe is that, so from steatosis to fibrosis, cirrhosis, and decompensated cirrhosis, how the molecular event takes place, there is a loss of NAD metabolism and defect in the energy metabolism, which occurs very early in the process of healthy to steatosis transition. That basically followed by the neutrophil-mediated inflammation, increased bacterial invasion, and fibrosis. And finally, from compensated to decompensated cirrhosis, there is increased cell death and regeneration failure. So this NAD is a very critical molecule in terms of regulating the metabolism, in terms of regulating the energy, activity, as well as the various stress response related to the redox balance in the cells. So we try to focus on this, and what we found, so if we talk about the NAD, you have basically three processes. The one is the de novo process, through where the tryptophan is taken through the kynurenine pathway to production of NAD. Second is the Perez-Hegde pathway, where you have the niacin or other intermediate molecules enter into the production of NAD. And the third most important is the Salvage pathway. So there also, so these three pathways are basically working to maintain the balance of the NAD or the requirement of the NAD during the homeostasis as well as in case of stress. And what we observe in case of liver tissue, so even if you see this de novo synthesis, IDO, TDO, when at the first step this is defective, very early, the Perez-Hegde, this Salvage pathway, NAMPT, which is also critical enzymes, that is also defective. Indeed, both in the animal model during progressions, you have the progressive loss of the NAD content of the liver tissue. Same to the animals, human liver tissue also shows the less amount of NAD. So does loss of NAD has any relation to the loss of macrophage function? So this question I asked, and the reason for that was that, so NAD, if we talk, the major pathway is the de novo synthesis of NAD. And using the carbon tracing, this experiment in this paper, the authors has clearly shown that it is the liver that is basically utilize the tryptophan directly to make the NAD. Rest of the organ is basically not using tryptophan or the precursor molecule for production of NAD. And during this process, they produce an intermediate molecule like NAM, which is mainly used by the rest of the organ for making the NAD for their need. So theoretically, if there is a liver dysfunction, and if the liver is not able to produce the NAD, then rest of the body will be in a deficit of the NAD requirement. So like liver, other cell types which has till now only shown is the macrophage, they also have the capacity for de novo NAD synthesis. However, this study claimed that whenever there is an infection or an injury or any inflammation, or even in case of aging, the de novo process of the macrophage NAD synthesis is compromised, and they are mainly dependent on the Salvage pathway for the NAD production. And this de novo defect in the de novo NAD synthesis in the macrophage lead to deplete the NAD pool, suppress the mitochondrial NAD dependent signaling and respiration, and impair the phagocytosis and resolution of inflammation. So now the thing is that if there is a liver, then the liver will be able to give them the NAD support. But if there is no liver, then it will lead a further deterioration of the NAD pool in the macrophage. So based on this understanding, we ask this question whether NAD level has any relation with the infection control. So we perform an in vitro experiment where we have challenged the macrophage with the LPS in the absence or in the presence of NR, which is a nicotine riboside nucleotide, one of the NAD precursor. And what we found that whenever you give the NR, you give LPS, there is a LPS-induced mitochondrial dysfunction. However, if you give the NR, they are not able to suppress that much. And indeed, in presence of NR-LPS, they have a better phagocytosis function. So in a way, in vitro data says that NR has some role in protecting the infection-induced damage to the mitochondrial respiration. Check whether this is acting in the in vivo system or not. So here we have taken the cirrhosis model, and then we, after the establishment of cirrhosis, we start giving them the NR as a supplement. And then we divided the animal into two groups, one where you have the CCL4 injury only, and where we have the with CCL4 injury, we have given the NR, and then we given the bacteria to the peripheral circulation, and then after some times we count the bacterial clearance. So what we observed that yes, the NR supplementation significantly increased the bacterial clearance in the cirrhotic liver. They reduces the 16S count in the liver tissue as well as the endotoxin level in the systemic circulation. When we search the literature, recently there are so many studies are coming up, particularly in the animal model, that says that NAD supplementation has some protective role in management of infection control. We summarize that loss of disease tolerance acts as a major driver of poor outcome of sepsis in liver injury. Early loss of NAD production by liver may account for bioenergetic dysfunction in macrophage, and that basically leading to the poor clearance of bacteria. And therapeutic use of MSC or NAD supplement may augment the disease tolerance in liver injury. Though we have the good antibiotic regime for management of the disease resistance, but we believe that together with this regime, if we can introduce the therapeutic approach which can take care of the disease tolerance like MSC mitochondria transfer or NR prevent mitochondria damage, can be a better approach for management of infection in case of liver injury. And with that thought, right now we are doing two preclinical studies where in one we are seeing the combination of NR and antibiotic in management of sepsis in cirrhosis. And in the second, we are using the therapeutic effect of MSC with antibiotic in management of SDP in cirrhosis, a preclinical study. Thank you very much for your attention. Any question?